You're listening to the UBC Medicine Learning Network.
Hello everyone, welcome to Metamorphosis. My name is Faye.
And my name is Donovan.
Here on the Metamorphosis podcast, we are interviewing various physicians across BC with the aim of learning more about their specialties and helping medical students navigate their medical careers. Our guest today is Dr. Winwood. Dr. Winwood, thank you for joining us.
And thank you, Faye and Donovan. It's a great privilege to be able to join you in this podcast.
Thank you very much. So Dr. Winwood is the Regional Associate Dean of the Northern Medical Program and also an internist and gastroenterologist here in Prince George. So Dr. Winwood, could you tell us a little bit about first your background and why you chose medicine and what your journey was like?
Oh, okay. That takes me a long way back. So, so as you can tell from my accent, if no one else knows, I came from the UK and I trained there. I was the son of a cardiologist working in a London teaching hospital. So I was brought up very much in an urban, metropolitan and academic environment. So I did have that background. I absolutely thought I had no chance of getting into medical school. And I just applied kind of thinking, well, I might as well do because I wasn't sure what else I wanted to do, and somehow I got into medical school. So that's how I ended up in medical school. And I trained at the London Hospital in East London, which is traditionally one of the poorer areas of London and has a large immigrant population. And historically, it's had waves of immigrants as they come through London. And it was a fascinating place to be. It saw a very diverse range of disease and social and socioeconomic problems. And I think from a fairly early stage, I was marked out to be an internist. I actually remember in a small group learning session, my tutor looking at me and saying, "He's going to be an internist," and I had no idea why he was saying that. I think I have some ideas now, but anyway, so and I think it's because I enjoy the intellectual challenge and I enjoy what I always call the diagnostic chase. I enjoy the kind of detective piece around trying to work out what's wrong with someone who's got an odd presentation. So, would you like to carry on into my career? Yeah. So I graduated from the London Hospital in 1985, and this takes me right back to why I'm here now in Prince George. I always enjoyed outdoor activities, and at every opportunity during my medical school years, and then a year as an intern, which I did in London, I was always trying to get out at weekends and trying to get to the country and go camping and hiking and stuff. Anyway, when I finished my intern year, I applied for residency rotations in internal medicine on the south coast in a regional hospital, and I think that was really where my career goals got solidified. So I did an internal medicine rotation in a regional centre, and with a larger population than we serve from Prince George, but probably about twice the size of the population. But we were seeing everything, and it was a smaller hospital with a much more friendly culture and working environment than I'd experienced in London teaching hospitals. And I really enjoyed at that time the acute medicine. I enjoyed the diagnostic challenge. I enjoyed seeing how people progressed as we treated them and following them through. And one of my attendings in those days was a gastroenterologist, and he was really, really widely respected across the region, and even in the local teaching centre, people really revered him as being the person you send patients to when you had no idea what was going on. And I do think that role modelling plays a part in our career choices. He was a fantastic internist and a fantastic gastroenterologist, and I think he really sowed the seeds. So from there, I applied for a fellowship program which had continuing internal medicine but gastroenterology, and moved to Southampton, where there's a teaching hospital and medical school. And I did effectively did my fellowship there And it's a different structure to here, but because, and along the way I got my Royal College exams. I worked with a famous gastroenterologist who had actually been involved in the discovery of hepatitis B. Within his group, there was another there was a senior fellow called Michael Arthur, who he was an academic gastroenterologist. He was just coming back from San Francisco and building his academic department, and he invited me to do research with him. And I spent 4.5 years doing research and working as a lecturer and a research fellow, studying liver fibrosis and cirrhosis. And as part of that, I got to spend 18 months in San Francisco on a traveling fellowship, and I had a fantastic time. And then I got to the end of that and actually decided that I didn't really want to be in a large teaching hospital after all, maybe, but I still wanted to be in an academic environment. And luckily, or maybe not luckily, I don't know, but as it turned out, there was a position that came up in the regional hospital where I'd done all my residency training as a gastroenterologist and internist, and I applied and got that position. And I was able to maintain my links with Southampton for the whole time I was there, and I was there for 12 years. And then from there, I came to Prince George.
So you mentioned earlier that you kind of got pegged as someone who should pursue internal early on. Can you kind of explain why you think that is?
Yes, as I said at the time, I didn't understand why my preceptor had said that.
Mm-hmm.
But I think for me, curiosity is a big thing, and intellectual curiosity, and that speaks to, as I call the diagnostic chase, the diagnostic challenge of dealing with an undifferentiated patient, trying to work out what's wrong with them. And that's a big part of being an internist. You need to be detail-oriented, which I'm afraid I am, and that's sometimes a bad thing in life. But as an internist, that's a good thing, because it means that, you consider all the possibilities. At the same time, you need to remain grounded in common sense and recognize that common things are common, and not try and diagnose the rarest disorder in every patient you see. But you need to consider it. So it's that. And then the other thing I really enjoy is the relationship that I develop with patients. And there is significant continuity of care, and in internal medicine, you usually follow patients through to diagnosis and initiate their management. And then it depends on what's wrong with them as to whether they might then go to a subspecialist or not.
How would you say internal compares to something like family, where you're seeing a really broad spectrum of patients in internal, you see a really broad spectrum of patients in family, but is it that you get to follow them further in internal, or what would you say the differences are?
I sometimes think the family doctors are the real clever doctors, because they have to deal with absolutely everything, whereas at least in internal medicine, we are limited to a spectrum of disorders that fall under internal medicine. In adults, so we're not dealing with peds, we're not dealing with OBGYN, etc. I guess the differences are that we get into the detail more. A family physician has to maintain that kind of grounding of common sense and pragmatic management of patients, whereas internists really get into the detail and get into the diagnostic workup in a detailed way. And I think. They tend to deal with specialized disease. They tend to deal with patients with multiple pathologies, with complex presentations, sometimes with one pathology with multiple, that affect multiple systems. So I think it's more about the detail and the specific management of complex patients. Yeah.
Do you think there's anything that would make someone not suited to a career in internal medicine?
I think if you don't like detail, then you're not suited to this career. For many people, it doesn't affect all specialties actually, and we'll probably come on to that, but many internal medicine specialties don't have a huge practical component. So if you like doing things with your hands, obviously you might think about being a surgeon.
How about gastroenterology itself? What made you want to, internal is a specialty by itself, and then you subspecialized even further?
Yeah, so I talked earlier about the role model, and I do believe that having a role model was a big part of my decision making. But having said that, I also liked the combination of what I've already referred to as the diagnostic chase, because GI diseases can present in almost any system, and diseases in almost any system can present as GI symptoms. So it still maintains a very broad base of disease types that you see as a gastroenterologist. In particular, I was interested in liver disease in my earlier days, and I've always found the metabolic black box that is our liver fascinating. And I've always found an intellectual challenge in following patients who develop liver disease and liver failure. So I really enjoy that intellectual challenge. On the other hand, it also comes with a significant practical component, and that's endoscopy. I enjoy the combination of doing a job where my intellect is challenged. At the same time, I can do practical procedures, and most gastroenterologists will spend 2 or 3 half days a week in endoscopy. And having said I enjoy the breadth of intellectual challenge, sometimes it's nice just to focus on doing one thing for half a day. And I really enjoy being in endoscopy, doing one thing, working with a team in the endoscopy room, mostly a team of nurses. And again, it's the skill of the procedure, it's the diagnostic challenge, and then there's a huge amount of therapeutic endoscopy these days that is also really enjoyable.
On that note as well, what would you say you spend most of your time doing as a gastroenterologist or an internist or vice versa, right? So obviously you're doing a lot of endoscopy. Is there anything else you spend you would say the majority of your time doing?
I still think I spend the majority of my time face-to-face with patients. And I do think that's important. Although I really enjoy the practical skills, gastroenterology is not about endoscopy. That's just a diagnostic and therapeutic tool that we use. So most of my time is spent with patients. In my gastroenterology practice, I would say around half the time is spent in the initial diagnosis of patients and half in chronic disease management and follow-up. And I really enjoy that side of the job as well. So my practice here is very rich in patients with inflammatory bowel disease and chronic liver disease. And those patients really need lifelong follow-up with a specialist. And there is still a huge art in the practice of medicine with those patients. There's no obviously there are algorithms, but there's no simple algorithm. Every patient is different. And I really enjoy that challenge.
Could you describe to us what a typical week looks like? For example, we know that you're the regional associate dean here, so you have a large role to play. And then also with your practice, how does a week look like for you?
So for my week, and my week is not typical of an internist and gastroenterologist. So I spend 4 days out of 5 working for the medical school. And that's not necessarily the same 4 days. And if I'm absolutely honest with you, I spend a lot of time in meetings, be they one-on-one meetings and very often large committee meetings, very often video conference meetings across the province. And I spend a lot of time responding to emails and sending letters. I'm involved in my regional associate dean role in everything from community engagement around trying to encourage communities to get their students to consider health professions programs, and particularly medicine, for their career, as well as encouraging those communities to welcome students and physicians later on, right through to curriculum development and oversight and faculty engagement, making sure that we've got adequate numbers of faculty and that they are happy with what they're doing and we're supporting them adequately, supporting students, supporting residents. So I spend 4 days of my week doing that, and sometimes I wonder how on earth that's possible, but actually I could spend probably 10 days a week doing that. And then I have a day a week approximately of clinical, and that varies. I do a half a day of endoscopy every other week, and that's usually a very busy list with usually nine patients I'm scoping with different types of procedure. And then I'll spend a day and a half a week on average in my office clinic seeing patients. And then on top of that, I do some internal medicine on call. And typically I do 2 nights or 2 weekend days a month of on call. And then I'll spend typically 2 to 4 weeks as the attending for internal medicine on the clinical teaching unit, which I also really enjoy because I do enjoy teaching, and fundamentally that's how I got into being the Regional Associate Dean. And I still enjoy being on the floor teaching students and residents at the same time as practicing clinical medicine and hopefully imparting a little of what wisdom I have to them.
What would you say are some challenges associated with your specialty in particular?
That's a good question. So every specialty has its challenging patients and challenging types of patients. And in gastroenterology, it's what I would call functional gastrointestinal disorders. And the one that everyone will think of when we say that is irritable bowel syndrome. And probably certainly in an urban gastroenterology practice, 40% of your workload will be seeing patients with functional GI disorders and effectively diagnosing them and providing management advice. And they can be very difficult because people are anxious. They often have quite severe pain, and they sometimes find it hard to accept that there isn't something seriously wrong with them. So they can be difficult, but also very interesting, and intellectually, functional GI disorders are fascinating. So from a kind of research and pathophysiological point of view, it's fascinating, but they can be challenging patients to deal with. And then I guess the other thing that can be challenging is endoscopy does need the resources. And so you do need to work in a centre where there are adequate facilities and resources for endoscopy. And then, of course, if you want to get into specialist endoscopy, then you need to have a sufficient patient base in order to keep up enough work that you maintain your skills.
So I know that you mentioned that you had a really good mentor that kind of helped you shape your journey. I'm wondering if you have any advice for students that maybe don't know where to look for that kind of mentorship.
Yeah, and it was serendipitous. It's just I came across these people when I was training. Students are always very keen to do shadowing, and I do think that's a good idea. On the other hand, you will encounter at least every broad specialty as you go through your 4 years training, and you will encounter people who may become role models for you. I think it's really tough for medical students in Canada that you have to make your career decision effectively as you come to the end of 3rd year. And I know that students are very concerned, often from the get-go, about whether they're going to match to the CALM specialty that they might want. And I would have to say that you do need to make sure that you do electives and things that you think you might want to do. I mean, you might learn that you don't want to do them. I would say that I do believe there's a number of careers I could have had in medicine and really enjoyed them as much as I have in gastroenterology. And I really believe that I could have done any of the internal medicine specialties, subspecialties, and enjoyed them. I really could. I might even have enjoyed surgery, but I don't think I'm smart. I'm clever enough with my hands to do that. I think I could have enjoyed pathology. I definitely could have enjoyed rural family practice. I would have had to have done rural family practice because I like a big scope of practice, and I like to follow my patients through. But no, I think you need to make sure that if you are interested in a career, any particular career, that you get exposure to it, and at the very least, you must do that in your lectures. If you can get exposure for some shadowing, that's a good idea.
How did you rule out those specialties, or was it serendipity, like you said?
I think it was largely serendipity. When I finished effectively my internal medicine residency, I applied for a GI fellowship, and I got in. If I hadn't got in, maybe I would have applied for a different type of fellowship. and I was thinking quite seriously about doing cardiology at the time. And the main reason I didn't was I kind of felt that I shouldn't be following in my father's footsteps. I wanted to do something different. That didn't feel quite right to me, although I think I would have loved cardiology. And that, of course, has a similar skill set, is if you like, is that there is the clinical side, and there can be some very difficult diagnostic challenges, and yet there's a big practical side. Most cardiologists now spend a lot of time doing cardiac catheters and PCI. And then there's echoes and stress tests and all sorts of other things that you can be doing. So, I do think I could have done certainly any of the internal medicine specialties, and it was just role models and that combination of intellectual curiosity and practical skills that attracted me.
You mentioned a couple different specialties that you could have done and been happy in. Do you think there's any that you absolutely couldn't have done or would regret doing now that you know a little bit more?
I honestly don't think I could have been a radiologist. I honestly don't think I could have done that. I really like people and patients. And I just don't think my brain is wired to be a radiologist. So I'm very much focused on the clinical presentation when I see a patient, and I go and look at an X-ray knowing the history and the physical exam findings, and I know I'm kind of looking for certain things and ruling out other things on the X-ray. I'm not very good at being shown an X-ray and just ask what's wrong with that X-ray. It's just not the way my brain works. So I don't think I'd have been very good at that. And I probably wouldn't have liked anesthesiology for many of the same reasons, but I enjoy the patient contact, I enjoy diagnosis, and there's not a lot of that in anesthesiology. You put your patients to sleep the moment you see them, and you don't really follow them through much after the OR. So I don't think I'd have enjoyed anesthesiology much. Many other things, I'd have enjoyed pediatrics. I thought very seriously about pediatrics. Yeah, same reasons, intellectual curiosity.
So you're practicing in Prince George here. What was it about Prince George or smaller centers generally that made you want to practice here as opposed to, I know you were probably trained in somewhere significantly larger?
Yeah. It's an interesting question, and I really believe that I am 100% suited to practicing in a community like Prince George. And I think I'm maybe relatively unusual in that I really enjoy the academic environment. I really enjoyed my time as a research fellow and lecturer in Southampton, and enjoyed being part of an academic team. And yet at the same time, I wanted to live in the country and work in the more kind of friendly environment of a smaller centre. And I, as I said earlier, I had enjoyed being in a regional hospital in by UK standards, a smaller centre during my residency. And it was interesting. So when I spent 12 years as a consultant and attending gastroenterologist and internist in a regional centre in the UK. And although by BC standards or even Canadian standards, it was quite a large community, it was not deemed to be a teaching centre, or it was a teaching centre but not a teaching hospital. And there wasn't enough academic stimulation there for me. We did have a lot of learners, and I had very significant leadership roles and teaching roles with learners, but I still didn't get the academic intellectual challenge that I wanted. And so I got to hear about Prince George and the Northern Medical Programme, again, quite serendipitously, really. And the idea of a medical school in a remote place in northern BC really appealed to me, because it would combine the lifestyle that I enjoy. I enjoy outdoor activities. I enjoy rural living, with being able to work in an academic environment. I enjoy teaching, I mentioned earlier on, so obviously huge teaching opportunities. And it came at a time when I was having to make some decisions in my career. Was I going to become a manager in the hospital and health authority, a clinical manager? I was being kind of directed that way. Would I do that and continue doing clinical work, which was not really what I wanted to do. I wanted to get back into academia. And And we've always enjoyed traveling, and we'd spent time in California and San Francisco and enjoyed that as a family. And so, and we had come to Canada on vacation and loved Western Canada and the outdoor opportunities. So for us, it seemed a perfect match, and it really has been.
On that note as well, what would you say are the main differences in internal gastroenterology for someone who's working in a smaller center?
I'll take internal medicine and then gastroenterology separately. So if you are an internist in a big center, and particularly a teaching center, you have almost immediate access to all the subspecialties that you want. And so someone comes in with chest pain and you think it's cardiac, you call the cardiologist. If someone's short of breath and you think they might have a respiratory problem, you call the respirologist. And that's not to say we don't have respirologists and cardiologists in somewhere like Prince George, but there are far fewer of them, and the type of practice we have is much more that the internist works up the patient and figures out what's going on, and when he's done that, they can call the subspecialist. So I think much more, if you like, independence of practice, the ability to see your patients through and start management across all the subspecialties. Usually, when as a gastroenterologist, the internist will have worked the patient up a long way before I get to see them as a gastroenterologist. They've already figured out they've probably got Crohn's disease or something, and they're really now asking me, and they've started management, they're really now asking me to take on the long-term and more complex management of that patient. So I just think that you get to retain that oversight of the patient's management for longer and more independently. Now that's good and bad. It might be that some people feel vulnerable and isolated, that they don't have the immediate access to all that subspecialty expertise. But I enjoy that. So as a gastroenterologist, working in a centre the size of Prince George, I have the opportunity to do almost everything that a gastroenterologist would do in a large centre. The one thing that I don't get involved in is the immediate operative management of liver transplants. I refer patients for liver transplant. I work them up for liver transplant. I follow them up once they've been discharged from hospital back to Prince George, but I don't get involved in that immediate management. And I would enjoy that for sure, because I've always also enjoyed acute medicine, and there's a lot of acute medicine around liver transplants. They're usually very sick patients when they come up to liver transplant, and their perioperative management can be, can be very difficult, and they can be very unstable. So that's the one thing I don't do. But in terms of just about everything else, I can do that in Prince George. We can do almost every advanced endoscopic procedure in Prince George. And if we're not doing it, there's no reason why you can't start doing it. I mean, with the exception of one or two really uncommon procedures where the volume doesn't justify it, there's really no limit to what I can do in my scope of practice as a gastroenterologist. I'm more limited myself by time than anything else.
So you mentioned earlier that lifestyle is one of the biggest reasons why you enjoy practicing in a smaller center. Could you talk a little bit about work-life balance?
I wish I could talk about it with wisdom, but so work-life balance is a challenge for all physicians, and I think it's a lifelong challenge, and will be for all of us. It is for me. Personally, I do enjoy being outdoors, and the fact that I can be home from anywhere in Prince George in 20 minutes, and I live out of town on the lake, to me is huge. And to give you a comparison, even where I worked in the UK, which was an 8-mile drive away from where I lived, it could take me anything from 30 minutes to an hour, 20 minutes to get to and from work, depending on the time of day.
Wow.
And so that is draining. And you don't feel like doing too much when you get home at night, when you've been sitting in traffic like that. So for me, the traffic and the population density is huge. The fact that I can get outside to a rural environment and get home and enjoy that, for me, is huge. And I actually just really enjoy being out in the yard doing yard work, believe it or not. But we have immediate access to a lake for various water sports and activities during the summer, and we're out there cross-country skiing on the lake in winter from our back door, which is just a wonderful thing to be able to do.
So I know that you were exposed a little bit to that outdoor lifestyle early on, and that kind of helped you make that decision. Do you have any advice for people that maybe grew up in a very big center that haven't experienced that before?
Give it a go. Try it and see. And it's really, I think that's really interesting. So, and forgive me if I go down the side road here, but one of the things that we're interested in for the Northern Medical Program is finding students who will be suited to working in smaller communities, and that's kind of our mandate. And that's not to say that people from the Northern Medical Program shouldn't be subspecialists in big centres, because it's always good if they have had the experience in a smaller community and understand the challenges for people coming from smaller communities. But there's a lot of evidence that if you were brought up in a rural and a smaller community, you are more likely to practice and be better suited to working in a smaller community. That's easy. But how do we find people who, like me, I was born and brought up in metropolitan areas. How do you find people like me? And if they've never been exposed to rural living or small community living, how do you find them? And it's an area that I'm really interested in, and trying to work out what the attitudes and behaviours of folk are that might enable us to select them. But I would say to those people, and I think UBC is really good at this, in that everyone has to do a rural family practice clerkship rotation. You should get out and try it. And you may or may not know, but I do some outreach work, and particularly into Indigenous and First Nations communities. And I did have the pleasure of going with a resident who's now in the Indigenous residency program, who was brought up in Vancouver and Victoria and had never stepped outside of those communities until she was a medical student and did a rural family practice rotation. And she said that changed her whole life. And now she's in the Indigenous program. She wants to work in small Indigenous communities. So I think you have to experience it. If you don't already know you have that calling, you have to experience it. And I think that's where the UBC program is good.
Regarding your specialty, gastroenterology, rural medicine generally, we were talking earlier about which direction you think it might be going in. What direction do you think gastroenterology internal is headed, especially in centers like this, smaller centers, or just rural medicine generally?
Yeah, so that's a really good question. I do think there is a kind of conflict between generalism and specialism in medicine nowadays. And I think it's not just medicine, I think it's the whole world, actually, in every field that you might want to look at. And there were, apart from the reasons I've given you for wanting to move away from where I was working in the UK, one of the things that I didn't like about my work in the UK was that whereas I started being a general internist with an interest in gastroenterology, I ended up being almost purely a hepatologist, seeing patients with hepatitis C and non-alcoholic fatty liver disease, and doing a bit of internal medicine on call, and that was kind of it. And to be honest, the intellectual challenge that I talked about started to diminish. On the other hand, it's very easy to be an expert in a narrow field and feel very confident in yourself. And we can't all be experts in everything. And so I do think there is a kind of increasing pressure to subspecialize. And yet if you're in a smaller community, we don't want people who can only deal with one or two diseases or do one or two things. We need people who can deal with a significant breadth of disease and have a wide variety of skills. So I don't know where it's going to go. I do think we're going to see increasing subspecialization, but in smaller communities, places in northern BC, like Fort St John and Terrace, you're always going to need a general internist and a generalist, just because the population cannot support all the subspecialties.
So there's obviously a tension there between the push to specialize, but also the necessity that a physician possess enough generalist ability to practice in a smaller setting. What do you think is driving that urge to specialize? Is it the volume of the information?
I think it is. I think that's exactly the answer, Donovan. I think it's the explosion of information that we have in every field of life, and it's impossible to keep up to date with it all. And actually, one of the reasons I love doing CTU is that the team help keep me up to date. So, in internal medicine, I heard some statistic that if you tried to read every paper that was published in a day, you couldn't do so in a lifetime nowadays. So, the explosion of knowledge is huge, and so you can't be an expert in everything. And that's getting, as life goes on, we're gonna narrow down what we can be an expert in over time. And I think that pressure is very hard to resist. And I see my skills as an internist now as those of experience and being able to bring some wisdom to the clinical approach, and knowing where I need to look to try and to gain the knowledge and information I need sometimes to know how to manage someone. And it's very different to when I was training, when and it's not to say we didn't look things up, but we hardly ever looked things up. It was only for a very challenging case we'd go and look stuff up to work out what was going on with them. Whereas now I very readily reach for bedside clinical supports like Up to Date, just to make sure that I know the latest way of managing whatever it is I'm seeing.
So I think we're getting close to the end of the interview, but I wanted to ask you what advice you have for undergrad students or even medical students that are thinking about what specialty they might want to go into. Maybe like what kind of questions should they ask themselves? Just what kind of advice you have.
Yeah, I guess, and this is where we started. It's all about fit. It's about what you're good at and what you enjoy. And apparently someone thought I was going to be quite good at internal medicine when I was a medical student, and I do enjoy the skills that you need for that. But I would also say to you, keep your mind open. I really do believe that I could have been happy in a variety of specialties. It might be that you are more drawn to a surgical specialty or a medical specialty. It might be that you just like to have the broad scope of practice and the relationships that you build in primary care, and therefore family medicine is the right thing for you. But keep your mind open. I could have enjoyed lots of things. And also, truly, and this is a tough pill for anyone to swallow at your stage, truly be aware of the career opportunities in the given specialties. So we all know that some specialties are harder to find positions in than others. And there was recently a report from the Royal College saying that there are a number of specialties where there are lots of trained specialists who can't find jobs in Canada. And so bear that in mind. If I didn't get into a gastroenterology fellowship, I was certainly willing to look at cardiology and respirology. I even fancied hematology. So, there were a variety of things I know I could have done and enjoyed.
One more question for you.
Yeah, so you brought up a really interesting point about knowing what opportunities are available for all of the different specialties, because I think, lots of people go into medicine for the job security, and that's a huge consideration, right? So could you elaborate on that a little bit?
When you say, you mean job opportunities?
Yeah, for example, do you know of any specialties where there are very few, or some that there are very many? Because I think people actually want to know that practical information.
Yeah. The challenge with advising you is that things do change. And so, for example, one where there's a shortage of jobs at the moment and too many trained physicians is orthopedic surgery. And yet the orthopedic surgeons will quite reasonably point to the fact that there are long wait lists for orthopedic surgeries around the country. And so it's not that we don't need them, it's that currently provincial governments have not invested in the resources needed to employ them. And so there's a number of there's a number of reasons why a specialty, why there may not be so many opportunities in a specialty. Plastic surgery is another challenging one to get into. On the other hand, general internal medicine there's going to be lots of opportunities there, particularly as you can subspecialize later on. Family medicine, there's still lots of opportunities. So I think you need to look at the data. CALMS have some really good data about what you need to do to get into a specialty. The Royal College have data about numbers of trained specialists and opportunities across the country. And then you need to just think about, and this is another hard piece, what are the opportunities likely to be? So I remember at one point in my career, they were saying there were going to be no jobs for cardiac surgeons. And this was when PCI, percutaneous intervention, came in, and cardiologists were putting stents and doing balloon angioplasties on everyone, and they were saying, well, there won't be any jobs for cardiac surgeons, because mostly what they were doing was coronary artery bypass grafting. But actually there's been a bit of a shift back, and we still need cardiac surgeons. So you also kind of need to try and read where the future might be in medicine.
Thank you so much, Dr. Winwood. It's a pleasure talking to you today.
And it's been a great pleasure talking to you, and I hope that I can inspire future generations of students to do internal medicine and gastroenterology.
Great. Thank you so much, Dr. Winwood.
This has been a presentation of the UBC Medicine Learning Network.